So Dr. Montes and I are going to cover PT best practices for walkers. And these are our disclosures. Nothing. Oh, here she is. Perfect.
Good morning.
There you go.
Thank you, Kristen. So similar to the format that was shared in the previous breakout sessions, where we plan to briefly review the standard of care recommendations for walkers. We'll use 3 case presentations, one of an infant, one of an adolescent child, and one of an adult, to discuss all aspects of impairments, activity limitations and participation. We'll touch on evaluations and assessments, but really focus on interventions and treatment plans and goals. Also then touch upon some general considerations and community resources. Next slide. So everybody filled out the polls, thank you. So the primary rehab goal for walkers are to maintain, restore, or promote function, mobility, range of motion, balance, endurance, and participation. Next slide. Back to the 2018 standards of care. As has been mentioned previously, we've outlined the signs and symptoms by function. So for walkers, the most important signs and symptoms to focus on are weakness, asymmetry, mobility, fatigue, specifically related to muscle endurance, falls, contractures and inflexibility, and endurance. Next slide. With regards to evaluations, the priority list seems to focus on timed test of function, the 6-minute walk test, mobility and gait evaluations, of course, range of motion and goniometry, exercise tolerance, and the Hammersmith for gross motor function. Next slide. And lastly, with regards to interventions, the focus for walkers are exercise, transfer and mobility training, range of motion, the role of aquatic therapy and balance exercises, bracing, fatigue management, as well as ADL management and ambulation devices as appropriate. Next slide. Dr. Chriselle.
Okay, so I'm going to talk first about a child who is treated pre-symptomatically. So he was a 4.5-year-old male who was destined to be type 2, was treated at 15 days of age, and he had 3 copies of SMN2. His age at diagnosis was 2 days of age. The family knew because he has an older sibling with SMA2 that was in a power chair at the time. His highest motor function achieved to date includes walking, climbing, running, and jumping, but you will see in some of the upcoming slides some of the problematic areas that he still has. He has no respiratory support and no major surgeries other than a 6th toe removal. And he started nusinersen, as I said, at 15 days of age. His PT has primarily been on a consultant basis only, with a family that does some really good follow through with home exercise programming. He's also involved in regular physical activity with his siblings, family, cousins, and does a lot of swimming, biking, and soccer. He does receive speech therapy weekly for some articulation and mild processing issues. So just to give you a quick overview, this is what he looked like very early on at day 1 of age, day 10. And it appears that we're going to have a glitch with that video. I thought we just solved this. I have to stop sharing for 1 second. I just skipped that slide. I apologize. Let's try again and see if we can bypass. We're going to bypass these videos if we can. Well, I don't know what the glitch is. We thought, sorry, I much apologize. We thought that we had resolved this. Sorry, I'm trying to go in the background and skip to the next slide so we don't. I was just telling Sally, I teach all the time, and this is actually the first time that I've had a major glitch. And so I do apologize. So those slides, those videos actually showed the child pre-symptomatically, where he really didn't look like he had any symptoms other than potentially some mild head lag. And then at 7 months, he was playing and cooing and babbling in some early imitation with his parent. His current impairments include mild proximal weakness and bilateral pronation. He has had some delayed gross motor skills all along with a slight delay in ambulation, but not outside of the typical. He started ambulating first steps at about 15 months of age. He has had some difficulty with stair climbing, but that is an issue as they don't have stairs in their home. Their home is fully adapted for his sister, who's in a power chair, and he has had some delays with ball skills. He does ride a two-wheel bike as of this year. He's always moving, and he loves soccer, and he doesn't really have any limitations in participation as perceived by the family. His strength, the only limitation really shows that he has some mild hip abduction weakness. His range is within normal limits. As I said before, he has mild pronation, no scoliosis or kyphosis to date, and his respiratory function is within functional limits. His CHOP score is 64 out of 64, and he achieved that probably shortly after the first year of age. His Hammersmith expanded score is 64 out of 66, and his WHO, he's achieved all of this WHO motor milestones. Where we see some limits or some delays potentially are in his Peabody. He was assessed with the Peabody gross motor skills. And what you see is that his age equivalent for stationary or balance skills seem to be on target for age at 46 months, but his locomotion, object manipulation, and visual motor integration are about 10 months behind, and his grasping at that time was about 6 months behind. This was about 6 months ago. His speech and language, he has some processing and articulation issues and does see speech therapy on a regular basis. Some other outcomes that were included that we look at with children like him are the 6-minute walk test. And the video that I'm about to show shows that, oh my gosh, I don't even know what to do. These have been playing like they played fine this morning. Is there any way to, oh, never mind, I don't know. Sally, are you still on here?
Yes.
Is there any way to join directly through Zoom and not through Zoom on the Hoover app?
So people are able to click on that and it's supposed to pop out into a different window. Jackie, do you have the slides you could try?
Kristen, I do have the slides if you want me to.
You do? Were you able?
I do.
Do you have the newest ones or the older ones?
I think they're as current as.
Okay, it doesn't matter at this point. I don't know what the problem is because these aren't. I apologize. Sorry. We were fine an hour ago.
the world of Zoom.
I know. I don't understand.
Can you see it? My slides?
Yeah. See if they'll well, when you play, see if it'll play the video. Okay. So if you watch and you see him kind of coming down the track, what you'll see is that he's on his 4th lap now. So initially he is pretty steady and he actually did a little bit of jog walk. It looks like maybe it's not playing anymore. Here he comes. So as he rounds the corner, you're going to see he needs a little bit of direction to potentially round the cone. And that's more, I think, just age related. As he passes the cone and starts to go so as he passes the cone and starts to go up the other way. Oh, okay. He shows some tripping, and we'll move on from that so that we don't lose time here. I think the key or important thing to point out here is that his timing, he makes it about 301 meters overall. He is at about 457, 65.7% for predicted age, with just a slight amount of fatigue. And he reports no fatigue at the end of that 6-minute walk test. Next slide, please. The family's short-term goals are to increase independence with stair climbing for greater community access, improve ball handling skills, catching, throwing, and dribbling, and to improve endurance to allow him to keep up with his peers on community outings and to monitor alignment changes. Next slide, please. As you can see here, just in his alignment, you can see that the slide in the middle kind of shows what his typical posture has been since he was quite young, with his legs abducted and a little bit externally rotated. He has pronation. The slide to your left is a most recent picture that mom sent me. He's always had a slight increase in the amount of weight bearing on his left leg, and you can kind of see that shift a little bit in this picture here. And then if you were to look at the picture on the right, what you see is he's sitting with his older brother. And what's most intriguing to me is that he actually has the better posture than his 8-year-old brother, which I think goes to the point on they've done a lot of work on strengthening. Next slide, please. I'm not sure why we're back to this. You can, you might just be able to see quickly here what he looked like early on, a little bit of lack of head control, but at 10 days, you wouldn't expect the best head control anyhow. And at 7 months, just playing typically in his crib with his mom. I would move to the next slide, please. These are his first independent steps. He's being cheered on by his siblings. They are sideways and staggered, but there was a lot of excitement here at 15 months. And then you can see here, he's taking his first, some of his first initial steps independently. We used to have to walk with him using 2 rails and a step tap pattern for both up and down. And if you go to the next video, Jackie, you can see he's climbing the stairs still in a step tap fashion just a few months ago, but independently without a rail at this point. Next slide, please. His fine motor skills have been on target, although the Peabody shows a little bit of delay. He does keep up with his peers. He loves to play soccer, and he's been involved in a soccer league this spring. And you can see him kicking the ball towards the goal, maybe. Yep, there he goes. So this was some of his initial attempts to get involved in some community activities. Next slide, please. And you can see here in this first slide, in the first picture, he is actually learning how to ride a tricycle at the same time as his brother that's about 1.5 years younger than him. But then he learned how to do training wheels on a bike at 4 years and 4 months. And just a very short time later, he progressed to being able to lead the way without any training wheels on his bike with his siblings on a bike ride on the driveway. Next slide, please. And then you can see him just getting an idea of him running and walking the dog down the pathway. He's going to come back up the pathway. And you're going to see, you know, he's not getting tangled up. He's not tripping when he's running around outside like this. And Sally, if you just bypass, that's his brother. But if we just bypass him for a second, yeah, you can just see he runs back to the end. But when the volume is on, you can actually hear him breathing audibly and being out of breath after that short run. But you can see that he's really able to do a typical everyday activity with his family. And then last but not least, his family just sent me this, and you know, the brother was learning to do burpees at school, and so the other 2 siblings got involved. So the little guy that we're talking about has the blue shirt on the right, and for a 4-year-old, I'm actually quite impressed that he could keep up with that. They were also counting at the same time, and he did a really nice job with that. Some of the other things that he does struggle a little bit with that were in the other deck of slides included his ability to transition up from the floor through half kneel. He typically just sort of jumps up from supine, which is what we would expect in a child his age, oftentimes if we come upon them unexpectedly. But when he asked to, when we ask him to transition up from the floor through half kneel, what we end up seeing is that he is a little bit weaker on one side and a little bit more abduction, and is a little more wobbly, but he is still successful. It's just a little bit slower for him than just jumping up. He does not exhibit any type of Gower sign. Next slide, please. And so I think that sort of just gives you a nice overview of somebody who was treated very, very early. And sort of if you think back to the child that Jackie just showed in the previous session that was treated a bit later, you can see that there's a distinct difference in the time that skill levels were achieved. And I think I also had wanted to point out that the child Jackie was talking about achieved, between 100 and 200 meters, and this little guy at 4.5 is getting 301 meters in a 6-meter walk test. So that's promising that he's on the track forward. And now Jackie's going to talk about a child and adolescent.
Thank you, Kristen. So this second case is a 14.5-year-old male with SMA type 3A. His age at symptom onset was 18 months with a diagnosis of SMA at 2. His highest motor function achieved is independent ambulation. He really has an unremarkable medical history except for, unrelated to SMA, a surgery for the transposition of the great vessels of the heart shortly after birth. He's been receiving nusinersen for 3.5 years. He started at 11 years old, and he has a real comprehensive therapy and physical activity program with outpatient PT, Aqua Therapy, and Shroth PT. And he plays sled hockey, which we'll talk more about in a little bit. So with regards to impairments, he exhibits proximal greater than distal weakness, legs more than arms. He has trunk and core weakness and scoliosis, which while it is less common in type 3 than in type 2, he presents with mild heel cord tightness as well. Some of his activity limitations include decreased endurance, fatigue, and difficulty rising from the floor and navigating stairs. With regards to participation, he finds it's sometimes challenging to navigate the school environment and keep up with his peers. Also with sports and physical education, he does participate in adaptive sports as sled hockey. With regards to evaluations and assessments, his strength using manual muscle testing exhibits largely normal upper extremity strength with some mild weakness proximally. He has weak hip flexors and quadriceps as expected, and his hip abductors are about a 3+ out of 5. As I had mentioned before, his ankle dorsiflexion range of motion gets to about neutral. His lower extremity alignment in standing is, he seems to have a functionally shorter right leg, and we'll talk a little bit more about that. He was recently diagnosed with scoliosis with a right thoracic 22-degree curve and a corresponding left thoracolumbar 31-degree curve. His respiratory function is normal. We performed the Hammersmith Functional Motor Scale Expanded, where he gets a 58 out of 66, and also used the revised Hammersmith, which has items that are higher functioning items that are good for walkers. He performs a 10-meter walk run and rise from the floor. Those are both also part of the revised Hammersmith. Takes a long time to get from the floor, and we'll look at a video of that. His last 6-minute walk test, he walked 415 meters with measurable fatigue at 14.5%. And we use the PDCAT as a patient-reported outcome measure. Here are his recent x-rays that were done as part of his monitoring for scoliosis. You can see in the left picture, so these are standing x-rays, just so you know. You can see the scoliosis and the curve, the thoraco and thoracolumbar curves. What I wanted to point out is that his pelvis in standing is relatively level. If you look at his ilium, there seem to be not too much, there seem to be symmetrical. But if you look more closely at his lower extremities, in this other picture, the femoral neck to shaft angle seems a bit more open on the left side. And then when you go down and look towards his knees, there's some additional valgus, as well as maybe some asymmetry at the joint line level here. He seems to be standing on his right leg with his left leg a little abducted. So here are some videos of him rising from the floor. What I think you'll appreciate is how very difficult it is for him. He first tries without using furniture, and he can't seem to figure out the best way to do this. It's really hard. And even when he uses support of furniture, it's effortful. When we look at another item on the RHS is a step up. He, with adaptation, is able to get up with the left leg leading, but the right leg, with the right leg leading, and now with the left leg, he's not really able to get up without help. Here's his 10-meter walk run. Let's see if it plays. And what I think you'll see is certainly the asymmetry and the sort of drop on the right side when he was weight bearing. And here's him walking on the 6-minute walk test. And you can similarly sort of see that drop on the right side. So for his goals, his short-term goals are to increase the ability and independence to rise from the floor, and to be able to better navigate steps and stairs to allow greater community access. Long-term, his goal is to improve his endurance to keep up with his peers at school and in the community. We thought we would show you some of his early development. We've been following him since he was 2 years old. This is him at 4 years old doing the Hammersmith, and this half kneeling item certainly highlights the proximal and hip girdle weakness that he has. This seems to be hard for him. Just go back. This is him getting from standing to sitting, squatting. He's not able to jump from 2 feet. And so in the child that Kristen showed, who is also 4 years old, who was treated, he navigates the stairs a little bit better than this little one. Here's him at 8 years old doing the 6-minute walk test. And while his gait is better than the 14-year-old one, you still see a little bit of that asymmetry, right compared to left. Just a little bit about his management of his scoliosis and other, he does also other musculoskeletal interventions. So he definitely performs heel cord stretching daily. He's really good at it. He likes doing the stair stretch. His parents help stretch, and he does other assisted like stretching, like long sitting with a belt that he can do himself. They prescribed a Boston brace for management of his scoliosis, which he's up to wearing 18 plus hours a day, which is pretty remarkable. And he's receiving Schroth method PT. And for those who are not familiar, Schroth is a non-surgical option for scoliosis. The goal of the exercises are to derotate, elongate, and stabilize the spine in a three-dimensional plane. I think Sally had touched upon it yesterday as well. Here are some of the exercises he does. The two panels here on the left are stabilization and breathing exercises. And he's holding the position with as an elongated spine and breathing into the activity. And then for elongation exercises, this exercise in standing, he's working on without raising his shoulders, elongating his spine, he's balancing, he's keeping his head neutral. And he's really enjoying that. He, you know, it takes some good body awareness to do Schroth, I think, but he certainly has it. So I mentioned he does Aqua Therapy. I just want to highlight here that they incorporate also, you know, the noodle and pool toys and stuff to sort of take advantage of the buoyancy and the resistance of water, both to get leg and arm muscle strengthening. And then in these pictures here, he plays paddleball in adaptive gym at school, but his favorite activity is outside of school, which is sled hockey. In this picture on the left here, he is in the sled, and he has a teammate that is called a pusher that helps him navigate the ice. He uses his hockey stick to manipulate the puck and also to help in pushing. And then he also serves as a goalie, which requires, you know, a lot of stick management and maneuvering to prevent the puck from getting in the goal. When he, with regards to durable medical equipment, he, in elementary school, had a positioning chair to encourage proper alignment. And when he was also around the same age, they got him a step stool to get into the family minivan. But right now he has no other current DME needs. So then I'll turn it back over to Kristen to cover our adult case.
Okay, thank you, Jackie. Next slide, please. So I just wanted to point out, we see a lot of questions coming up in the chat, but because we had a little bit of a delayed start and we have a hard stop at 11, we're going to progress through the end and then answer the questions we can if we have time, and otherwise we will be answering them in the chat. So this is a 32-year-old female. I apologize for that typo, type 3B. Her age of onset was in childhood, where she presented with fatigue, frequent falls, and some clumsiness and what she felt was awkwardness in her movement. Her official age of diagnosis, based on where she lives and some different incidents with different physician follow-up, she was officially diagnosed at 20 years of age. Her highest mode of function achieved, as you'll see, is independent ambulation with stair ambulation with a railing, which she did better when she was younger, but has always needed a rail. Currently with lower height still, she can take a few steps without a railing. And when she was younger, she could do a slow run, but can no longer run. She's never used respiratory support, had any surgeries, and is currently, and this is important to note, not on any disease modifying therapies. So her presentation will look different. She does participate in daily workouts at the gym. And then during the pandemic, that was decreased a little bit from for the first 4 months of time. And she also meets with a physical therapist weekly to every other week. The PT comes to the gym and also works in jointly with the trainer. For side activities, she enjoys kickboxing, swimming, and tire rolling, which you'll see what that is at the end. It's intriguing. Next slide, please. So this just kind of shows her getting out of bed in the morning. And I point this out to show that, it's not like she can just hop up out of bed. There's some definite effort there. Now we do know that her bed is somewhat lower, but there's definite effort, and she does report fatigue and a little bit of morning stiffness early in the day until she gets moving. I think her quote is important, where she states that I used to go to school 20 minutes early because my classroom was on the 3rd floor and there were no elevators. And one of the girls used to tease me about how I would grab onto the rails and almost twist my body just to get up the steps. And you have to remember that was prior to her having a diagnosis. And so we can all imagine how that felt at that age. Next slide, please. So overall, she has proximal weakness, just like the other two have had. Fatigue, poor endurance, balance issues. Her balance is much more fragile than these other two that you just saw. Poor core strength, and is now starting to report pain. And actually, she's very good about her workouts. It's not directly related to a workout. She tends to have and report pain more when she's inactive. She felt like her pain actually increased during the beginning of the pandemic when she was more restricted. Balance and falls are problematic. She falls a few times a day. Longer distance ambulation is an issue for her, and floor to stand and bed transfer. She lives independently on her own. She moved away from her family and actually moved to a whole different country so she could have full independence. However, that has also presented with some challenges. She is active in her community. She has a local gym membership and is very social with friends, and has met different people through support groups as well as through her gym community. She's self-employed as a relationship counselor. Next slide, please. So I don't have any recent assessments because I have typically been following her sporadically through telehealth. Her strength, typically what the PT there has looked at strength and myometry, range of motion, alignment, force vital capacity, and changes in falls. Most of these things have pretty much remained stable. She actually has more hypermobility than limited mobility at this stage, particularly at the knees and the elbows. And you'll see that in some of the activities that she does. For assessments, some of the best functional assessments to look at would be the Hammersmith expanded or revised Hammersmith. She has been followed and had the 6-minute walk test and 10-meter walk run done. She's also had the time to rise from supine tested. And last I remember that it was well over 100 seconds. It might have actually been close to 2 minutes. And you'll see her try to attempt that in a slide that's coming up. I have not seen a time to climb 4 stairs, but she says that it has been done in the past. And one of the other tools that has been looked at is the modified SMA FRS, which gives us a little bit more information about her own independence with dressing, feeding, and being able to manage on her own. Next slide, please. So her short-term goals were to maintain or improve her strength for independent ADLs and function, and this goal has been ongoing for quite some time. She also wanted to improve her ability to rise from the floor, which I think has now become more a longer-term goal, improve her balance and reduce falls. And one of her other long-term goals when I started meeting with her was to walk 10,000 steps a day to improve and maintain fitness. Next slide, please. So she participates in a lot of strengthening activities, including upper and lower extremity strengthening with and without resistance and with weights and machines that you'll see a few examples of. She is active in aerobic exercise and does strengthening and aerobic. She sort of flip-flops days, although she probably does aerobic exercises 3 times a week and then strengthening maybe more like 3 to 4 times a week, although she does alternate. On days she does uppers and some days she does lowers. And if she does lower extremity strengthening, she does probably upper extremity aerobics on the same day. She does core and mat work, and she says that's usually 3 to 5 times a week, and also works on functional training like the transitions on and off equipment, chairs, down to the floor and back up. She walks daily, and then she is also involved in postural and alignment monitoring. Next slide, please. So you can see here, these are some of her routines. And so these are without weights for upper extremities. And when she initially started this task, she could just about bring it up, could barely bring it like to shoulder height. And now you can see she can bring it all the way up and can move it off. And this was actually her 6-month goal, which she met. But initially, as I said, she started and could barely bring that up to shoulder level using 2 hands and actually had a smaller wall when she first started. She worked on these 2 to 3 times a week, 8 to 12 reps, 2 to 3 sets, which are within the standard of care guidelines. And she uses control of the ball through various range. Next slide, please. And then if we look at sort of adding some weights now, and considering that she's doing 6 to 12 reps, 2 to 3 times, 2 to 3 sets, she's using a % of her 1 rep max. And this takes her several weeks to months to progress. She sometimes will not add a plate on the arm lift machine for probably 6 to 8 months, but she's not gone backwards and she's been able to maintain a fairly consistent approach to things. She feels like, you know, over time she has definitely gotten stronger, but it's taken a long time to move to the next level. And we've had a lot of discussion about moving to the next level before the former's correct, because that's what happened initially when I first was meeting up with her. And so she's really sort of backed off on that a little bit. Next slide, please. So here you can see she's now added some machine lower extremity activities. And if you watch the slide to the left there, you'll see when she's going to start to abduct, once she gets that side going, you're going to see that she actually has to use her hands to get into the machine and then to actually do her AD abduction to assist initially, where she's in the light turquoise shirt. And then in the next video next to it, you can see she's sort of progressed to being able to do it without having to assist with her hands or her arms to get started. So you can sort of see a little bit of a difference there. She also has to stabilize a little differently. They were at different time periods, so she's definitely progressed. And then up above, I think this is just interesting to note that how little hip flexion against gravity she actually has. And how quickly she has to do that. She can't really maintain it up against gravity for any long period of time. We've talked about slowing it down. She really can't. And then if you watch her hip extension, one thing here I think to be noteworthy of is the compensations that are happening in the other part of her body. And as you can see, she's almost using more momentum and some trunk extension and trunk flexion to try to get through a little more range instead of backing off and doing that as she is in the other video. Now you can see she's doing it at the ballet bar with much more control with no weights on. And then the bottom video, this is just showing you her transition. She's going to transition down to the floor, and then she's going to do some hip extension here, anti-gravity. In a few minutes, you'll see that same position when she does a transition. But what's interesting here is she's really here working on strengthening. The trainer is right up in front guarding her, because if she collapses, it's more at the upper extremities than the lowers, or that's where she feels less safe. And she also has to get some guidance when she goes to do the other leg, because she's definitely not as strong on the other side in trying to do the lift. The next slide, please. And so these are some of the things she does for core and mat work routines. You can see here that just even pushing up in prone with elbows flexed to get some thoracic extension and chin tuck is not the easiest task. She's doing a bridge with a weight, her forward bend with the weight, and then you can see the weight with rotation. And I think the weight with rotation is interesting because initially, the first time I saw this, she had a larger weight and far more compensations. And so always the lesson is you need to move back on your weight and really work till you can have good form and control and sort of slow movement and repetition. So just to kind of show a variety. Next slide, please. And these are some of her aerobic routines. So she works on a rower, typically 3 times a week. She can reports an omni of about 6 out of 10 and can do it for up to 20 minutes with very minimal resistance. You can then see her on the side here doing biking. And I think what's interesting here is you get the top one is an earlier time period where she actually had to use her hands to push her legs on the pedals. She does use foot straps to maintain her position and to maintain her feet on the machines. And then the last one in the middle there, Jackie, shows her on the treadmill. And you can just kind of see her progression. I want to point out her shoes, they're interesting. She's worn the same style and the same type of shoes for 5 years or so now. She reports that while they don't seem to give a lot of stability, they make her feel most stable and most comfortable. At one point, we did try orthotics for a little bit of added alignment and stability, and she could not tolerate them, but and has not really done well with tie shoes because it really limits her independence overall. Next slide, please. And then this is her working on her sort of stand to floor routine, and you can just very much appreciate the hyperextension, the hypermobility in the shoulders and the amount of effort that was to go down. And then as you watch her, you can see that she has to really strategically think this through to get herself back up to stand. She knows to turn and try to stabilize the one foot against the wall. But she says this is where it becomes problematic if she falls in her house or is out in the community and not near a place where she can get some initial stability. She also is on a non-skid mat there that makes a huge difference in her being able to begin to achieve this. But you can even see as she goes down the hypermobility in her elbows, on her legs as she lowers herself. And so we have to be very cognizant of long-term integrity there. She's not developed a scoliosis at this point. And as I said, she actually has hypermobility versus any limited mobility. Okay, next slide, please. And as you can see, she uses Aqua Therapy. There's a warm water pool at her apartment complex, and she goes in 2 to 3 mornings a week in the early morning to sort of loosen up, get some range of motion. She does kicking. She also does a lot of arm movements. And then she also uses the noodles and does a lot of walking and laps in the pool as Jackie's other person did. And she sometimes can be in there for up to 30 minutes. And then this just kind of shows it's a very brief clip, unfortunately, of her sort of walking in the community. And you can just appreciate that, you know, she, other than the fact that she has some knee hyperextension and maybe has a little bit of a hip drop, you probably wouldn't notice much else. She tends to walk 6 to 7 times a week for 30 to 60 minutes. And she was able to increase from 2,000 to 8,000 steps a day after 8 months. Albeit she walks slowly and she still has a fear of falls. She says that, you know, the fact that she goes so slow, her omni is only up to between a 3 and 6 out of 10, depending on what else she's done that day. She tends to do her walks after she's worked out, rested, gone home and napped, and then gone out for a walk. Next slide, please. And then just some things she enjoys on the other side of enjoyment, but also work on some of her strengthening endurance are both kickboxing and tire rolling. And tire rolling is something that's outside the back of her gym. They have different size and weighted tires that people roll across and move across the lawn. There's also a hilly area that she says she cannot do because she gets knocked down every time she tries to end at the top of the hill. And she'll do that some days for 45 minutes in lieu of some of her other activities. And thinks that both of these have really helped a lot with her balance and stability. Next slide. She, as I said, she's tried shoe inserts with poor tolerance, and she has no other DME needs currently. Next slide, please. And so I would encourage you to think about accessing these links that were pointed out yesterday and the day before, as far as great resources for some PT education, outcomes, and different continuing ed opportunities that can continue to provide support for your work in the community with your patients. And next slide. So just in summary, key interventions for walkers would typically include things such as strengthening and stretching, maintaining mobility, transitions and transfers, monitoring for alignment. As you can see, even in the 2 patients that were treated, there were a little bit more alignment issues along the way than there are in this in the last adult scenario. But they're something that we need to keep our eyes open to at all times. And then balance training and falls management, I think for all 3 of these patients are probably important. Next slide. So we just want to thank you for attending and listening.